Welcome. Thanks so much for joining us this evening. I apologize, I was a little late, just trying to get home, and of course, an accident, which kind of wrecks everything in terms of timing. So hopefully this will be educational for all who have joined, and it can be hopefully interactive as well. So, what I wanted to start with for those people who are not familiar with myself, so I am a fellowship trained urologic oncologist, and actually, I started out my career in academics. So out of fellowship, which I got at the Mayo Clinic in Rochester. I went straight to Penn State Health, which is in Hershey, Pennsylvania. That's the kind of state, medical university, and practiced all types of urologic oncology there, as well as was the residency program director. And then in 2021, moved out to beautiful Colorado, colorful Colorado. And here I took the job with Colorado Urology as their bladder cancer lead. So, what has been happening, certainly in a lot of disciplines across medicine, and urology is no different, is that the amount of information and new technology, new drugs and therapeutics that are blossoming, it's really becoming hard for the kind of generalist or general urologist to keep track of this all. And so we're having these disease team leads, as we call them, to kind of head up kind of the education of our group, as well as to help again, better direct patients along their disease journeys as these new therapeutics and diagnostics come into play. So here I do a lot of other advanced urologic oncology, help with prostate cancer, kidney cancer, and as well as help have rolled out kind of our administration of a drug, kind of a cousin drug, which is used in bladder cancer called immunotherapy. All right, so what we're going to talk about is to give you guys an updated 2024 bladder cancer statistics overview, who is at risk. We'll go over the stages of bladder cancer and focus on this concept, which if you met with myself and potentially, again, other urologists might use kind of what is your risk level when we talk about superficial bladder cancer and non-muscle invasive bladder cancer. And then we'll go into some of the novel diagnostics that are out there for both non-muscle invasive disease as well as muscle invasive disease, as well as review traditional and new therapeutic options for both those two different disease states, and then clinical trials that we have ongoing. Okay, so to start off with, in the past year, so in 2024, we are at still over 83,000 people in the US being diagnosed with bladder cancer. So that's the estimate for 2024. Ultimately, that breaks down to a whopping 228 people per day hearing the words, "You have bladder cancer." This still, though, represents only, even though it sounds like a huge number, just 4.2% of all new cancer cases in the US. Now, this does, though, translate to the individual. So you say, what is my individual lifetime risk of developing bladder cancer? Just any average Joe out there. It's actually 2.2% for all comers, all kind of US population. Now, in 2024, it's estimated that we'll see high 16,000, so specifically 16,800 deaths caused by bladder cancer. Now, again, looks like a big number. It is a big number, especially if it has involved a loved one. But this does just represent 2.8% of all new cancer deaths, okay, in 2024. Now, the numbers with bladder cancer, when you put it into perspective, is that currently, again, and this still is the same, this was the same in 2023, that in the US today, there's over 700,000 people living with bladder cancer, and that still is more than the population of Wyoming. Now, for Colorado, kind of what are our statistics? So in 2024, we're estimated to see 1,200 new cases. Okay. And then you see here kind of what we just said, kind of the new national cases are estimated for 2024 is over 83,000. Specifically broken down by gender, we'll see 63,000 new cases specifically in men, approximately 20,000 cases in women for 2024, and that's what's the estimated number to unfortunately pass away from their bladder cancer in 2024 alone. So there is a concern that bladder cancer cases may be increasing. When we look at the statistics from one year to the next, from 2024 backwards, it doesn't show that right now. It actually shows it's pretty stable. But the concern is this, that with the aging US population, we're projected to see quite a bit of an increase by 2030, projected as 68% increase. So that's quite a bit. So bladder cancer remains, and it was this last year too, the sixth most common cancer. And that's pretty remarkable, I think, when people hear about that, because until many times they've been diagnosed, they have a family member or friend. Many people haven't really ever heard of bladder cancer. But as you can see here, of course, breast, this is all comers, men and women. Breast is number one, two, prostate cancer, three, lung, four, colorectal, and five, melanoma, and then six is bladder cancer. Again, this still represents just 4.2% of all new cancer cases in the US. Most common ages of diagnosis, certainly it is a cancer more of older age. Median age at diagnosis 73. It's most frequently diagnosed between 65 and 74, but actually over 90% of our cases are in age greater than 55. But you still see that we do capture bladder cancer in our younger patient population. And there is a concern, we don't know why, but a lot of us feel that we are seeing kind of a rise in the younger population. It certainly disproportionately affects older adults. So, unfortunately, among our older than 80 years old, there is 179 new cases per 100,000 patients. Of course, these patients have a high rate of morbidity. Many times they have a median of 8 chronic conditions already. Bladder cancer deaths are highest among patients who are 85 plus. And this probably likely makes sense. These patients, right, have a number of other comorbidities. They're frail, have a lot going on, and bladder cancer is a serious diagnosis. So over 60% of deaths actually occur over the age of 75, and 32% of those deaths are in 85 plus patients. So the gender predilection for this cancer is remarkable. So men are 3 to 4 times more likely to be diagnosed with this cancer than women. Okay, so 1 in 27 men are diagnosed with this cancer versus 1 in 89 women. Now, unfortunately, though, women are more likely to be diagnosed at an advanced stage. And this is because one of the presenting symptoms, okay, of course, is blood in the urine, but can also be urinary tract infections. And so, unfortunately, for our female population, we kind of are plagued as we get older with recurrent urinary tract infections. And many times that gets presented first to the primary care physician, and they're trying to figure out what's going on, treating with antibiotics. Many times the culture is positive, it's looking like an infection. But after we've had a couple of these, we've tried to educate our primary care physicians and hopefully to educate our patients so you guys can be your own advocates, is that after we say you have been defined as having recurrent urinary tract infections, which is 2 urinary tract infections in 6 months or 3 within a year, you need to be passed off to urologist because we need to do what I call an anatomic evaluation. Look at the whole urinary tract, make sure there's nothing as the cause for these recurrent infections. And we see this in women, that one of the very common presenting kind of symptoms and platforms of symptoms that we see is these recurrent urinary tract infections. And because it's a delayed diagnosis, often then once we get to the diagnosis of bladder cancer in them, it is at an advanced stage. So in terms of the kind of predilection for race, we do see that more, again, the kind of white or Caucasians are more plagued with this cancer than other races out there. Now, survival statistics. Everybody wants to see what are the survival statistics of bladder cancer. So I will tell you with presenting this data, this is kind of also the law of averages and everybody combined. Okay. So in general, all superficial bladder cancer combined with muscle invasive disease, metastatic disease, etc. So some very advanced forms, the 5-year relative survival is 78%. Okay. So what that means is, again, you've been diagnosed, 5-year passes, you have a 78% chance, unfortunately, of surviving, okay, to 5 years. Whereas, again, this would translate to about kind of 21, 0.6% of patients, unfortunately, passing within those 5 years. Below are graphs that kind of break down a little bit in regards to kind of the percentage of cases we see, okay, out there by stage. So in situ means superficial bladder cancer originating just in the first layers, to localized bladder cancer, meaning, again, muscle invasive, but confined to the bladder, no lymph nodes or anything like that. Then we have regional, 7% present at this stage, and those are spread to the local lymph nodes in the pelvis. And then 5% where the cancer has become metastatic, spread to another organ in the abdomen, to the lungs, etc. And 4%, of course, is unknown. And where this data is being captured is, again, nationwide by reporting systems or cancer registries. So you can see here on the right-hand lower corner, the breakdown of, survival, 5-year survival per stage. So of course you would expect that as we parse this 78% out, that we find that our patients with superficial bladder cancer have actually excellent survival odds at 5 years. The majority of people are alive, yes, with their cancer, hopefully not coming back, but certainly not passing from their cancer in 5 years. Then, of course, the statistics go downwards from there. When it's into the muscle, again, all comers, that means all types of treatments done, sometimes even no treatments. This is all come stage, okay? Goes down to about 72%. So 72% survival at 5 years, and then downward from there, about only 40% survival for when it gets into the lymph nodes, and then metastatic, unfortunately, 9% survival at 5 years. Very importantly here, when I present this data, a lot of people want this to see this, is that this data is, again, based on large groups of people. No two individuals are alike. This is not parsing out as to what treatments people received. Okay. So treatment and responses to treatment vary greatly. Okay. So these are, again, averages, okay, across, and does not get into the minusculeness about, again, the individual, okay, their disease state and the treatments that they embark on. Okay. What are the risk factors? Smoking is the number one risk factor. It accounts for 40%, 47% of all cases. So I say it's kind of like risk factors 1 through 5. But then we have other, risk factors. So we talked about age. Okay, so certainly the risk of bladder cancer increases with age. About 9 out of 10 patients are older than age 55. We have certain exposures. Okay. These are not as common anymore as it was kind of decades before, where we had a lot more of our patients as with, again, painters, hairdressers, with these dyes and fumes that are thankfully more regulated these days, mechanics, leather workers, stuff like that. Certainly has been shown to increase risk of bladder cancer. These are some more common medical things. So there are certain patients that have exposures to previous chemotherapies that can increase your risk. These are what's called benzene or aromatic amines. That was in those dyes and fumes of the painters, hairdressers, mechanics, leather workers. This is what is attributable, okay, to increasing your risk of bladder cancer. And then for some patients, we have seen people that have chronic indwelling catheters that can increase your risk too. It's a very low risk. We've kind of gotten away from mandating screening of patients with an indwelling catheter anymore, finding that likely this was kind of a red herring that these patients already had other risk factors and they had an indwelling catheter. And so it wasn't the indwelling catheter that caused that increased risk. Certainly, family history of bladder cancer increases an individual's risk. We talked about race and ethnicity. Caucasians are about twice as likely to develop bladder cancer than other ethnicities. And then gender. Men have a significantly higher rate of bladder cancer, 3 out of 4 than women. Lynch syndrome. This is probably getting into the weeds, but it is actually a kind of cancer syndromic kind of disposition, which can increase one's odds for developing a urothelial cancer. Many times more of it, what's called an upper tract cancer, cancer in the ureter rather than the bladder. Okay, so the stages of bladder cancer. Here gives your overview of kind of the stages. We have carcinoma in situ. That's a very flat cancer, but again, remains superficial, but can be very aggressive. Superficial bladder cancer is called TA or papillary disease, or T1, where there's some roots going into the lamina propria layer. Then we have muscle invasive disease, where that cancer is going deeper with the roots into the muscle layer. T3 disease, where that cancer is going through the muscle layer into the outer fat layer. And then certainly T4 disease, where it's getting into a subsequent organ, whether it's the vagina in women, the prostate in men, the rectum, etc. Okay, so superficial bladder cancer, again, this type of cancer resides in the inner layer. Most layer stays superficial there. It can present as a papillary tumor. We can see it when we're in the bladder doing cystoscopy. It kind of shows as like almost like a broccoli or a sea anemone, kind of like a coral reef, or it can be sessile, okay? And then that carcinoma in situ can just look like a red patch. And it is very, what I call an elusive disease, can be missed. And we'll talk about certain technology that's out there that can help us pick it up better. So the majority of patients are diagnosed, okay, with superficial bladder cancer. So, when we present those odds in 2024, over 83,000 patients are going to be diagnosed in the US with bladder cancer. Greater than 60% of patients will be diagnosed just with superficial bladder cancer. And remember those odds, really good odds of surviving this disease at 5 years. You might ask, why do we use this 5-year mark? Well, we have to use some sort of mark kind of to estimate, again, survival. Now, looking here, again, 5-year survival, 96%. I think that other graph, serum Medicare data, 97%. Here shows kind of the percentage of, again, that, greater than 60% superficial bladder cancer. 20% of those patients are T1. The majority are this TA disease, and then 10% are CIS. I will tell you that a lot of us are thinking these days that a lot more patients have CIS and just have not been diagnosed because it is elusive. This data is from what we call white light data, old kind of historical data. All right, so again, as probably majority of you are aware, how we diagnose this is by cystoscopy, by visualization, and this can be performed in the what we call local setting, not necessarily under general anesthesia. It's a direct visualization of the bladder lining, figuring out, is it healthy or is it an area of concern? And of course, how most people come to us with this disease is presenting with blood in the urine that they can see, sometimes microscopic blood that they can't see, sometimes incidentally just found on imaging, okay? Or sometimes those recurrent urinary tract infections. So those are the most common kind of presenting kind of signs and symptoms that we get that then leads us to the cystoscopy to understand, is there something there of concern? Okay, so then after we understand, yes, there is something there of concern, we're undergoing resection. Okay, TURBT, so that's trans urethral resection of bladder tumor, TURBT. So yes, this is performed in the operating room. It has to be done under general anesthesia. Can we do this sometimes if this lesion is super small, patient has a lot of morbidity? Could we do a little what we call biopsy under local anesthesia with that flexible scope, biopsy a couple times, burn that area, get an understanding, is this something, of cancerous versus not? That can, yes, be done. But when there is an obvious papillary lesion, we perform this because this procedure is what we call one of the main cornerstones of treatment for superficial bladder cancer. We want to mechanically evacuate that disease, which those little biopsy and burn snippets can't always do fully. Okay. Thankfully, many times patients don't have to stay in the hospital. Sometimes, many times, you have to leave with a catheter for a bit of time. And that is just to explain how I explain it is that again, we create a raw spot, almost like skinning your knee, okay, inside the bladder. What does the bladder do? The bladder expands and contracts. If we keep asking the bladder to do this phenomenon, the bladder cannot scab over, cannot heal. So that catheter keeps a nice drainage, bladder in a nice little comfortable decompressed state, allows that scab to be generated, allows the bleeding to typically resolve more quickly. Okay, so again, the purpose is to scrape this thing out, get deep enough, okay, to get it all out of there if we can, if it's superficial, and to sample the muscle. So the purpose of this crucial procedure is determining tissue type. Is it truly bladder cancer? Does it have any unique cells in it called a histologic variant? The depth of the tumor. And this is one of the cornerstones for treatment of superficial tumors, okay? Now, this is one of the new technologies out there. Hopefully, you've heard of it. It's been around actually for quite some time. Unfortunately, it is not widely diffused. Okay. What I mean by that is a lot of hospitals do not have this technology. Currently, our ambulatory surgery center does not. And this has to do with reimbursement issues that, again, our codes, if you will, dictated by insurance and Medicare and all those great large players in healthcare. I do not feel that, again, at least at this point in time, this technology is, if you will, kind of worth its while. They are starting to come around as more and more evidence is coming to light that this technology is very useful. And so right now, it's not what we call well, I'll just use reimbursable in the ambulatory surgery center setting where we do a lot of these procedures. Thankfully, the hospital, okay, system, it is reimbursable, okay, meaning that if we have this technology, insurance will kind of pay the hospitals back for, again, its use. Okay, so it's not kind of done at a loss, for example. So the hospitals, therefore, are willing to purchase the technology, okay, for us to use it because it is a separate, very unique technology that, again, either, a company like Colorado has to purchase to get in their ambulatory surgery centers or a hospital system has to purchase to be able to do this. Interestingly, because this technology, and I'll go through the slides here in just a second to explain it. Interestingly, because it's becoming so useful, there are starting to come to light to date these third-party vendors that bring, for example, technologies to the setting where the surgeon's going to operate, as long as there's kind of this vendor contractual agreement, will bring the technology to you, which is a game changer and has been a game changer. We use it in a lot of other disciplines like treating kidney stones and lasers coming in, etc. So thankfully, these third-party vendors are starting to do this for this technology, which will help diffuse the technology to a lot of urologists so they can use it. Right now, the urologist somewhat is handcuffed by, again, the places that they operate. Do they or do they not have this technology? Okay. So what this technology does is ultimately it helps us see the cancer better. So we instill this agent, okay, this kind of a luminescent agent into the bladder. okay, via a catheter in the pre-op holding area. Okay, you the catheter comes out, you hold this imaging agent in the bladder for at least an hour, then we whisk you off to surgery, put you to sleep. Okay, then the proceduralist, drains, okay, this agent. Okay, and during that 1 hour, the cancer cells are absorbing this kind of photoactive agent. Okay. And they do so because this agent is taken up by, in general, blood vessels. Okay. And cancer has a lot of blood vessels. So once we drain it, then we use a unique scope and technology. Okay. And we shine a blue fluorescence onto the walls of the bladder. And areas where there is cancer kind of illuminate as pink, okay, fluorescent pink. So we're able to both see where specifically, again, maybe elusive carcinoma in situ is lying and detect it, where under white light, when I gave you that 10% kind of total percentage of those patients, that was just under white light. And again, under white light technology, the typical technology we use with surveillance cystoscopes and typical with TURBTs, sometimes we miss, okay, CIS under this. With this sort of optical imaging agent and the blue fluorescence, it helps us detect, again, cancer, which might not be obvious to the white light, again, kind of magnified vision that we have currently. So this not only helps us to better clear cancer fully and make sure that that scraping of the bladder is doing what we need it to do, the complete mechanical evacuation of the patient's disease. Right? So you can clearly see and remove all the cancer. It actually also helps with the margin of the resection too, okay, to make sure you got it all. So, what the data shows with this type technology, specifically with Cysview, we'll go into narrowband imaging in a second. It actually improves cancer detection by about 25%, both at diagnosis, initial TURBT if it's used then, and then also in subsequent follow-up scrapings. So we ultimately, patients that underwent this type of technology versus compared randomized to just using white light, they were found actually to have more cancer detected and evacuated. And actually, long-term results looking, okay, so we can detect more cancer, but does this affect, a patient's outcomes? Well, it seems to that it does decrease your rate of recurrence. So it goes with the philosophy that if we're able to clear out more cancer within the bladder at the time of this really important procedure, then yes, patients overall do better. They see less of that cancer coming back. Okay. And it does seem to prolong the time to recurrence. Again, one of the nuances of superficial bladder cancer we'll go into in a second is that it just keeps coming back or just has a high likelihood of coming back. Use of this technology can also prolong the time to it coming back because, again, we do a better job scraping. So let's go in now to the kind of risk stratifications that we use for superficial bladder cancer. So this is based on kind of our American Urologic Association and Society of Urologic Association risk stratification for bladder cancer. And this is only for superficial bladder cancer. We put people into buckets: low risk, intermediate risk, and high risk. And this is really defined by your stage of disease, number of tumors, okay, and if you have high grade or low grade. So high grade and low grade has to deal with how those cells look under the microscope. High grade looking more aggressive, low grade looking not as aggressive. Why we put people into these risk categories or buckets is to help the provider get you correctly to the next step, which is, do we need any further therapy? Okay, meaning in the bladder intravesical therapy, or should we even be putting on the table to start that discussion with you of the option of more invasive therapies like bladder removal? Okay, a lot of us specialists in the field really feel that there should be a higher risk category called a very high risk category. So these are patients that unfortunately have a number of the high risk category together, okay? Meaning they have such as T1 high grade plus carcinoma in situ, or they have, again, what's called a variant histology. So they might have just this TA disease, not too bad, but a large tumor, sarcomatoid variation or micropapillary variation, cells trying to transition away from the typical looking urothelial cancer. And LVI means lymphovascular invasion. Why we're even thinking that there should be a fourth category is one, our European colleagues actually have a fourth category. Two, when people have a number of these high risk features together, the risk of progression of disease to muscle invasiveness to metastatic disease skyrockets. And so it is an effort to try to kind of help the practitioner with that patient to kind of start to talk about potentially more aggressive treatment options, such as bladder removal. Okay. All right. So we talked about that for superficial bladder cancer. The cornerstone of treatment is that resection. We might need possible intravesical therapy. That's dependent on your risk stratification. And then, of course, after we've gotten you through that and during maybe that intravesical therapy course, we're needing to do close follow-up, cystoscopy and imaging. So that visualization is key to understanding if that cancer is coming back. So really superficial bladder cancer, as the odds of surviving this cancer are high in the majority of cases, it really becomes a burdensome chronic condition. So follow-up is extremely important. We kind of alluded to this earlier, these high risk of recurrence. So here for all comers together, okay, TA disease, T1, CIS, risk of recurrence at 1 year, 61%, goes up from there. At 5 years, 78% of patients have a recurrence. High risk of progression, 17% at 1 year, 45% at 5 years. I will tell you, the risk of progression really is kind of beholden to kind of these patients with T1 disease and some patients with CIS disease. Okay, this doesn't hold as much for our patients with TA high grade disease and certainly not low grade disease. So what are our agents intravesically to treat? So actually, the recommendations definitively in our guidelines are to give intravesical agents many times for intermediate risk patients and high risk patients. Okay, so for intermediate risk patients, it's recommended to consider that as an option. High risk patients, we should give intravesical therapy. So the standard of care for now over 50 plus years has been BCG. This is an inactivated kind of tuberculosis virus. Okay, there's many different forms. Here's labeled kind of the TICE formulation that we most commonly use here in the US. Yes, probably a lot of you know that there has been a supply shortage going on and kind of started kind of around that 2020 year and is still continuing, has kind of lessened up to some degree, but still an issue for some practices out there. However, BCG has been a great therapy. It's actually classified by many of our bladder cancer experts as the best immunotherapy out there for all cancers. Why? Because it can achieve what's called a complete response in up to 80% of patients. The unfortunateness is it's not durable. So meaning that treatment, good control doesn't last. Okay. And that's really where we get those risk of recurrence numbers. Those are patients that have undergone treatment. And so it just usually by kind of year one, sometimes up to, again, 50% of patients reported on that past slide, 61% of patients can recur. Other agents are to give intravesical chemotherapy, gemcitabine, a combination of gemcitabine and docetaxel, mitomycin. Unfortunately, a lot of patients in the high risk category develop BCG unresponsive disease, 50%. So it's a real issue of what to do with such patients. And thankfully, nowadays, we have a lot of new FDA ready to use therapies, but they are for a very niche right now population of patients with superficial bladder cancer. They are for only patients in regards to insurance will pay for patients that have specifically CIS, that carcinoma in situ superficial disease that has become BCG unresponsive. And what it means to become BCG unresponsive is a very complicated definition. Yes, you of course have to have received BCG, you of course have had it responded, but actually it is really dependent on the number of BCG installations you've had and the duration by which then you've recurred. Okay. And that's where someone like me helps a lot of urologists determine, yeah, we don't want to give that patient any more BCG. They are now defined as BCG unresponsive. We need to transition on. So certainly BCG unresponsive can happen to patients that have TA disease, can happen to patients that have T1 disease. Okay. But unfortunately, the new FDA approved drugs that are out there are only approved for CIS BCG unresponsive disease. These drugs, I will tell you, will get approved for other superficial bladder cancers and will get approved for earlier on in the disease state, meaning be available ultimately in the future for patients at time of diagnosis. But all these drugs, always with cancer drugs, start out for patients that are in the most critical phase, okay, of their disease state. And this certainly here is a critical phase, okay? And so that's where it got approved for first. That's where all the clinical trials worked on for the past 10 years and got this approved. Now, all the trials we're doing with these drugs are in earlier disease states and at different stages of disease, too. So, the first one we'll talk about is called Adstiladrin, okay? Nadofaragene firadenovec. Adstiladrin. Okay, so it is an adenovirus vector gene-based therapy for interferon 2b. Okay, we're seeing a 53% complete response rate at 3 months. This is great. It might not seem that high, but these are for patients that their disease has outsmarted again, remember BCG, the best immunotherapy out there. At 60 months, patients, there's 25% of patients that are still disease free. Okay. Amazingly, this drug is very cool. It's only given in the bladder every 3 months. So you no longer have to worry about once a week, okay, getting therapy. This drug has figured out a way to just be given every 3 months. There is some updated data because it's being explored. And remember, I said in other stages of disease, and we're seeing even a better response 73% complete response at 3 months. And at 60 months, 48% are remaining disease free. So just how this works, it's actually a non-replicating adenovirus with this interferon gene, with this other agent tagged to it, given into the bladder. And ultimately what this does is the virus enters into the urothelial wall and into the tumor cells, and the gene is transported into the nucleus. And then that gene is read out, proteins are produced, which then enact this whole kind of cascade of interferon-induced tumor cell cytotoxicity mechanisms, which are kind of shown here. So a little biology, molecular biology for you here tonight. So what is Adstiladrin? It is interferon alpha and 2b protein into the bladder so it can fight the cancer. Okay. It is a targeted treatment. It works with your body's immune cells. And again, it's given every 3 months. The next drug out there is Anktiva. It is an interleukin 15 superagonist. It is given with BCG. Okay, so it's given very similar, okay, as BCG has been given. So once a week for 6 weeks, and then there is a maintenance phase. 62% complete response at 3 months, all right, and at 24 months, 40% remain disease-free. So how this drug works, it works by activating the body's natural immune system to fight the disease and provide long-term, okay, immune memory against the cancer. Okay, so it kills cancer cells, which evade T cells, kind of stimulates the natural killer cells, as it's called. It kind of stimulates killer T cells, okay, which primes what's called memory cells. And then it also, again, generates those memory cells, which recognize bladder cancer cells over time and continues that killing mechanism to decrease the recurrence. All right, the third drug, which we won't go into too much, has been around actually for multiple years now. It's pembrolizumab. It really was the next drug, again, or the kind of laid the groundwork as to what we do with patients that have become BCG unresponsive. This is your immunotherapy, pembrolizumab. It's a PD-1 inhibitor. It's given IV, so very different therapy from what our superficial bladder cancers or patients are used to. It's given IV every 3 to 6 weeks for 2 years. We see a 41% complete response rate at 3 months, and the durability seems, yes, to be about 2 years. Okay. All right, so now let's transition for our last kind of remaining time here to talk about invasive bladder cancer. So invasive bladder cancer, again, is when that tumor is having those roots deep into that muscle wall, going through the muscle or into the muscle, through maybe and beyond. 33% of patients are diagnosed at this stage. Again, 5-year survival is not as great. All right, localized disease, we said 72%. Okay, 5-year survival. Regional disease, meaning having those lymph nodes seen on imaging, 40% 5-year survival. And then when we have metastatic disease, it's 9% survival at 5 years. Now, with this disease, we have to do a lot more, right? It's a lot more aggressive. All right. We have to do a lot more aggressive treatment. So it really necessitates a multidisciplinary care team, a urologic oncologist like myself, medical oncologist, radiation oncologist. So the options going forward are as such. Many times we need to use either radical surgery, bladder removal, sometimes chemotherapy first for multiple months, followed by bladder removal. And that seems to have the best survival, advantage as compared to doing what seems to be easier, and certainly is, chemotherapy concurrent with radiation therapy. All right. Thankfully, there are a lot of clinical trials out there looking at how we can preserve the bladder in patients with invasive bladder cancer. So looking at combining immunotherapy IV with an intravesical agent, plus or minus surgery and radiation. So one of the very cool tests out there, only available right now for our muscle invasive, or invasive bladder cancer patients, is this novel diagnostic tool called circulating tumor DNA. It is a blood test, and it is a unique blood test generated for the individual patient, trying to and does identify the cancer DNA. And then this company, Natera, generates, based on the patient's scraping tissue sample, and getting their blood, generates a specific blood test and biomarker for that individual patient. So such blood tests cannot be used with another invasive bladder cancer patient because they will have different cancer DNA. So this test is looking for an individual's known cancer cells floating within their body. So it's really the first biomarker test out there. Does take a while to make, and we'll go over that in a second, but is a very unique test that now we can use concurrently with imaging to understand, is the disease coming back? And many times there's a great, what we call lead time with this test. And I'll show you in a second here. So ultimately, just to read the slide, it predicts disease recurrence early, before traditional imaging methods, and it's used to help predict and monitor treatment response to help us clinicians make better decisions for the patient on the next steps. So how Signatura is used. So it's used to predict, again, disease that's likely to recur without further treatment. It's many times used after surgery, to inform the benefit of needing further treatment. So if we don't detect any of these, circulating tumor DNA in the blood after surgery, surgery did it. We don't need to have any other therapy, And then we can continue to use this test going forward in time to make sure the cancer is not coming back, along with following the patient with imaging. So here's just an example: 65-year-old man, muscle invasive bladder cancer, okay, gets the Signatera test, okay, before undergoing any treatment, okay. We see a high load of this circulating tumor DNA in the plasma, in the blood. They undergo cystectomy. That amount of circulating tumor DNA is dropping because now the bladder cancer is out of the body, okay? And then we would measure after surgery, usually kind of 6 weeks or so. And if there's no circulating DNA detected, okay, as it's shown here, then that patient is again in remission, okay? Cancer is gone. We keep checking, all right? For this one example patient, we see that circulating tumor DNA now spike up in the blood, okay? And on month 3 after surgery, it was detected. This indicates to us likely now the patient is should move on to further therapy to kill these floating circulating cancer cells, okay? So we can use it again in the before surgery setting. If we're able to get this test generated, it does sometimes take up to 4+ weeks. And many times we already have an idea of how to move that patient forward in treatment, and we want to move that patient forward quickly. So the company is trying to figure out ways to expedite, the creation of this test, but it just does take some time. So often this test is used after, again, surgery or that initial, again, treatment, chemotherapy surgery, et cetera, or chemo and radiation, then to be used is the cancer gone. Okay, so in the adjuvant setting, okay, then also in the surveillance setting, again, and of course, also in the metastatic setting, as those patients are undergoing treatment too, we want to see, have we killed all those floating cancer cells? So it's really a biomarker, really nicely to help guide clinical decision making. We are all so excited that this is available. It's available for a number of other cancer types too, like breast, et cetera. And so soon we'll be seeing these individualized tests become more and more common. Okay. And obviously the production of them will become easier too. Okay. So what is some novel treatments in kind of the invasive bladder cancer realm? So for specifically locally advanced or metastatic bladder cancer. So locally advanced, we were showing already on initial diagnosis. We know we have muscle invasive disease, or maybe even through and through that wall, but the imaging, okay, has shown that we have lymph nodes present, or maybe we have metastatic bladder cancer where the cancer is spread to another organ, the lungs, et cetera. This new combination of therapy called an endorphamab vedotin plus pembrolizumab, it is a non-chemotherapy regimen, really has revolutionized kind of our landscape of treating, again, these advanced stages of bladder cancer. It has been shown to increase what's called progression-free survival and overall survival, double it, than standard chemotherapy. Okay. This evidence just came out last year. And so ultimately, a lot of medical oncologists, that's who would administer this therapy, have really transitioned to this therapy in our patients that, again, have lymph node positive invasive bladder cancer or metastatic disease, because the odds of, again, battling this cancer are so much better with this drug combination, which thankfully is not a chemotherapy. It also has less serious side effects. We grade side effects in terms of grade 1 through 4. And really, we show that grade 3 and 4 are very serious side effects. So we always report trials out in terms of what is the grade 3 side effect profile. So we see grade 3 side effects for this combination is 56% of patients develop grade 3 side effects versus 70% with chemotherapy. So a drastic difference. And what these little graphs show here is this is how we present kind of our drug data and progression-free survival. These are little hash marks, are patients, actual patients over time. And you see this new combination in the orange is showing a much better, again, outcome for our patients than the standard chemotherapy shown in green. Okay, so just to briefly go over kind of surgery, because a lot of people have a lot of questions about, God, what if my cancer progresses to muscle invasive disease, or we might be already struggling with muscle invasive disease, and what does surgery look like? Because unfortunately, surgery is still kind of the mainstay and the best curative option for invasive bladder cancer that is localized, and many times too also for our locally advanced bladder cancer patients that have lymph nodes. So for a cystectomy for the man, we do remove the bladder, the prostate, the lymph nodes. Okay. For the woman, we remove the bladder, the lymph nodes, many times the uterus. And then often we can spare the ovaries and fallopian tubes, dependent on the patient's age, okay, and still need for them. And certainly we spare the vagina. Now, in terms of urinary diversion, so how now do we get the urine out that we took the bladder away? Well, we use the patient's own small bowel. We either create what's called an ileal conduit, which is taking a short segment of small bowel, 20 centimeters, connect it to those ureters, and then the tube of bowel then drains to the body wall into a pouch that you do have to continuously wear. It is covered up, okay, by clothing, very discreet. You can swim in the ocean, you can fly, in the sky with these. So these should not be life prohibitive, but it is something you have to get used to. There is what we call a learning curve, just getting used to your new setup. But many people live full lives with urine diversions. So this is just kind of how we do it, some kind of more kind of technicality to it. We have to cut that small bowel and hook it back up together. That piece of small bowel is still connected to its blood supply. It's still living, it's still part of you. And then we connect it to that body wall and to the ureters. And this is kind of the final picture of how those ureters are connected to that piece of bowel that then goes to the body wall. The other type of diversion that we commonly use, there's many out there, is the neobladder. So the neobladder is where we actually use more of your small bowel, okay, to we actually take a total of 64 centimeters, okay, to make the neobladder. And again, it's still connected to your small bowel. The ureters are kind of plugged into the top part, what we call the chimney of the neobladder. And then the majority of the neobladder sits into the pelvis where your original bladder sat and is connected to your urethra. Again, the decision by which kind of diversion an individual chooses is really up to the individual. There are a couple of medical criteria that does prevent us from doing the neobladder. Sometimes really bad kidney function, we can't do a neobladder. Many times, if there is cancer disease at the level of the urethra, we can't do the neobladder. Okay, for patients that have trouble with, for example, a lot of dexterity. Okay, we need patients to actually catheterize this neobladder for a while to make sure it is up and running. Okay, because these things do not work like normal bladders. All right. All right, to end our discussion here, as we only have a couple minutes left, is our current clinical trial. So thankfully, over the past, really 10 years now, and certainly over the past 5, there has been just a lot of energy in the bladder cancer field. A lot, mostly in the superficial bladder cancer, but also in the muscle invasive disease state, to where pharmaceutical companies are interested in this disease state, wanting to develop drugs and are pushing forward. Okay. And that's really who we need to push forward these drugs. We unfortunately need these pharmaceutical companies. And so this is just to highlight the studies we have here in Colorado Urology. So we have it for all different kind of stages of disease. You see again, I'll start out for our muscle invasive disease. We have 2 trials for patients not interested in surgery and for patients that don't want to undergo chemotherapy before their surgery. Then we have for patients who have intermediate risk disease, who need that intravesical therapy. There's 2 trials we have for those patients. And then we have a variety of treatments for patients who are initially diagnosed, okay, and have high-risk disease. For patients who have high-risk disease, but they might be initially diagnosed or what's called exposed to BCG or unresponsive to BCG. And then we have things, as there's many definitions, BCG exposed. So you've had a dappling of intravesical BCG therapy, but the cancers come back. Recurrent high risk cancer, and for those patients that still have that BCG unresponsive high risk disease. So certainly, if there is interest in clinical trials out there, your provider hasn't talked to you about clinical trials, you feel you may be eligible, please feel free to, again, ask to, again, about clinical trials. If your provider can't talk to you about clinical trials, I'd be more than happy to talk to you about that. I'd be also more than happy to talk to you about if you just have questions that you feel are just not getting answered. Are you on the right track? Colorado Urology is very collegial, and that if one of our patients wants to kind of meet with kind of the expert, the lead, we have a lot of opportunities for virtual visits, etc., to provide you more of that education if you desire. So thanks so much for joining us.